the go-ahead to start, and the sound's better. So yes, welcome everyone to the Health and Wellbeing Board, this November meeting. My turn to chair. It's obviously a blended meeting, which has its own special set of IT challenges for someone like myself. So we'll put in a request for a little bit of kindness if I miss hands, and generally it doesn't run quite as smoothly as I'd like. But anyway, I'm sure we'll be all right. So it hasn't, there isn't a theme for this particular meeting because we'll be discussing the health and wellbeing strategy and the JSNA process. We have a number of other items as well. So without more ado, the usual kind of house rules, please remain muted if you're not speaking. If you're joining us remotely, I'll look for hands, as I say, before speaking, and people in the room are putting up their hands as well. Chat function isn't doing anything. Just want members to actually speak out, which is great. One thing to note, we will have a VCS membership update as of presenting next meeting to get the membership just revised in that regard. And I know I welcome people who are joining as a sort of attendees today from the VCS, and we'll wait to formalise that next time. So I know we have a number of apologies. Councillor Farhana Thomas is going to be a bit late, but will be joining us for total apologies from Dr. Sandra Husbands, Mayor Philip Glanville, and Ayman Ali. Have you got any more? No. Okay, super, thank you. So declarations of interest. Anything anyone needs to declare regarding today's particular agenda items? Oh, hi.
Hi, just a general
Can you just say who you are? Just.
Oh, sorry.
Okay, thank you very much. I can't see any more hands. Thank you. So going on to the minutes of the previous meeting, which are in the pack. Has anybody got any points to correct or clarifications they want to note? So are we happy to agree those? Thank you very much. We have an action log. In fact, the first three actions essentially will be on the forward plan of 2022. I know action 3, and I can see John Williams in front of me, but John, maybe just easier for me to quickly read out the fact there's been a bit of an update on the action 3, which is Healthwatch have met with the public health since the last Health and Wellbeing Board meeting, and now working with Health Inequality Steering Group to progress the community engagement plan. And this work will be carried over to the next couple of months with the aim to have a clear position on community engagement. From that, we can develop the community engagement plan for the city, for Hackney's Health and Wellbeing Board. So that's a bit of progress that's ongoing, and hence it will come back substantively in the forward plan for probably next year. And the other actions are closed. Largely, 2 of them are on the agenda today. And unfortunately, action number 6, the bid that it refers to as unsuccessful, so won't be proceeding. Now, we haven't got any questions from the public. Anybody, sorry, I'm rushing on a bit. Comments about any of that? No, fine, thank you very much. We haven't got any questions from the public, so I'm not dwelling on that item. So we have got to the first substantive item, which is the draft Health and Wellbeing Board strategy. Sarah Bainbridge is on the call. I saw you a moment ago in a little box. It's going to present for 10-15 minutes, so then we've got about 15 minutes or so to discuss it. And in fact, we're being asked really to approve the draft strategy, which is paper 8A in the back, and which will then be published for consultation for the next 12 weeks. We're being asked by generally to, we know different ways to promote that engagement process as much as we can, and then consider the draft consultation questions, which are in paper 8C. So I might just return to those asks at the end to make sure we feel that we've done them justice. So Sarah, over to you for the next 10-15 minutes.
Thanks very much, Chair, and good afternoon, everyone. I do have a few slides just to help us guide through this particular item. So please do let me know if you can see that okay. So my name's Sarah Bainbridge. I've been part of the team to put together the health and wellbeing strategy for 2021 to 2022 to 2026. And as Dr. Rickett said, I'm just going to be introducing this item to take people through a little bit more about the draft strategy, but we're hoping to leave most of this time for discussion. So as a reminder, the health and wellbeing strategy has been in development for a number of months. As the chair said, our main aim for today is to move us on to the next step, which is going to be launching a draft strategy for consultation. Last time the board met in September, our engagement phase was still underway, but a prioritisation workshop using some of that engagement insight was held on the 1st of October with some of the members of the board. So it's been a journey to get here, and I'll be recapping a little bit of that journey before we talk more about the strategy itself. So hopefully board members have had a chance to review the draft strategy. I'm going to just give you a very quick recap about what we did during the engagement, what we did before that, and more recently, our prioritisation. So how have we got here to a draft strategy? We started off with some analytical work earlier this year and a workshop with the King's Fund back in May. Over the summer, and this is what I mentioned was still continuing in September, there was a huge amount of engagement. Over 600 participants took part in that engagement. We had a survey that was open for residents. We had peer research thanks to Hackney Volunteer Centre, and we had several stakeholder workshops. All of that engagement has been put together into an engagement insight report that was an accompanying paper for the draft strategy, and we'll also be making that available with the consultation. And what that engagement showed us was that there were issues that people had already recognised were impacting on their health and wellbeing, and those issues were raised by both residents saying what they felt was important to their health, as well as the stakeholders we spoke to. So we've taken all of that insight, looked at the data we have, and looked at the existing work that we know is already ongoing. And thanks to the prioritisation workshop that took place at the beginning of October, we have identified 3 priorities for action. The 3 priorities that have come out very strongly from the engagement and from the prioritisation are improving mental health and preventing mental ill health. The second is social connection and making sure we don't have people who are feeling isolated and lonely, as we know that social connection has a huge impact on health and well-being. Our third priority is financial security, making sure that we reduce poverty in the borough and that we can reduce health inequalities that stem from that financial insecurity. We have data and insight that sit behind each of these. And just as a reminder, as is stated in the strategy, these are just 3 priorities where we feel that the board can make the most difference over the next 4 years to health inequalities, especially working as a partnership. Of course, other work is already starting on many other health and wellbeing issues and is going to still be ongoing. So it's not to say that if something isn't a priority, it will have no work or action on it. It's just saying that these are the 3 priorities that were felt most pertinent for this particular strategy and for this partnership approach. Of course, turning these 3 priorities into a strategy will require further action. We have used a framework from the Michael Marmot review in 2010, which uses 6 objectives to actually reduce inequalities. This is a way of approaching each of those so that we can apply each of them and say, what actions would we need to give each child the best start in life, to really think about enabling children, young people and their families to maximise their capabilities, thinking about employment and good work, a healthy standard of living, as well as making sure we're developing healthy and sustainable places and strengthening the role of prevention of ill health. So we're using that as a useful framework to make sure that we're tackling each of these areas with that inequalities reduction goal in mind. So we have shared the draft strategy with some Health and Wellbeing board members, especially those who have been part of its development and some who haven't been able to join the discussion today. And we thought it might be helpful to just present back some of that feedback so that it prompts further discussion from the board this afternoon. One of the key areas that has been raised is to make sure we're really setting out our vision or ambition for each of these priorities, making sure that this strategy really challenges ourselves and that we can see where we'll be aiming to make real progress. We've also heard that it's important to balance the current issues that are facing everyone as part of this board right now, as well as balancing that with the need to transform for the future. So it's impossible to ignore someone who might need healthcare today, whilst making sure we've got the right balance with action to prevent ill health in the future and reduce those inequalities that could cause ill health tomorrow. And finally, we need to make sure that we're not just making this, this isn't just lip service. We really need to show where improvements are needed, making sure these indicators are monitored and making sure we're measuring progress. So those are 3 bits of feedback that we'll be trying to incorporate into the draft strategy before it is published for consultation. I will be leaving lots of time for discussion, don't worry. But just to finish my segment, I thought I'd give you a quick introduction to our consultation approach. So if the board are happy with the draft, we will make amendments and then would like to publish for 12 weeks consultation. The consultation, we're hoping will really build on the engagement that took place over the summer, and the aim is to make sure the strategy has the support of people across Hackney and that it really gets translated into action. We want to make sure people take part in the consultation and feel that this is their strategy and really share their suggestions, and to make sure that these suggestions are coming from diverse perspectives. We are in conversation with Hackney Volunteer Centre to build on our successful peer researcher model, and we'll be asking throughout the consultation for suggested actions to make sure those priorities and reducing health inequalities really comes to the fore. And the consultation won't be very long. We're trying to make sure that it's short and snappy so that people will respond. But we're asking questions around whether people agree with the actions that we're suggesting for each priority, whether other actions could be suggested, and who should be involved in taking action. And we're working out a plan at the moment to make sure that we've got, as I said, peer researchers involved, but also that we're speaking to stakeholders across Hackney who could be part of taking action for this too. So just to finish up, a reminder on next steps and our action planning. So we will be amending the draft strategy that you've had ahead of this meeting based on the feedback and discussion we're having today. We'd then like to publish for 12 weeks. And I think it's important to make sure that we bring this to life with real action. So the intention is to create task and finish groups for each priority and our ways of working. These task and finish groups would include a peer researcher, so that this is co-produced with people who are resident and live in the borough. And we want to make sure that we are working out those ambitions and indicators to show success for each of the actions we'd like to do. So I'm very happy to take questions, but also I think we've got a big chunk of time for discussion now. And just to remind everyone of the questions that we've presented in our update paper, I think our questions are really, does anyone have any questions or suggestions for the draft strategy? And then the sort of yes or no $64 million question, does the board approve the draft strategy for consultation? And finally, does the board have any suggestions for engaging people with that consultation? So I'll hand back to you, Dr. Ricketts, so that people can discuss the strategy.
Great, thank you very much, Sarah. Did you want to just, in the paper 8B, or the one with the suggested questions for the consultation, did you want to just highlight some of those for us now?
Yes, of course. So our questions for the board were really just around, in terms of approving the strategy, did you mean, or?
What I had in mind was the draft health and wellbeing strategy consultation questions, because obviously I just want to make sure people have seen that before they make suggestions about other questions, because you may have already incorporated it in your
Yes,
work.
of course, sorry. So one of our appendix papers were the draft questions that we're proposing to consult on. So it's a paper, I think, as you said, 8C. I may have got the numbers wrong. So we're asking people just about themselves, the usual information, so that we can make sure we're hearing from a diverse range of people. And then we'll be asking people for feedback on each of the 3 priorities. So we're asking, in the draft strategy, we're including actions. Do they agree? And to what extent do they agree or disagree with the suggested actions for our first priority, which is on mental health? Asking people to explain their reasons and if they can suggest other actions and who should be involved in those. And then we replicate that for the next 2 priorities. So we're also asking if people agree with the suggested actions for the second priority, social connection. Again, do they think there's anything else that should be included in terms of actions around that priority, and who should be working on those? So we're really focused on turning this from priorities, which we've heard from people through the engagement, into that action plan that we think will make a real difference to reduce health inequalities.
Great, thank you, Sarah. Should just, Peter sent me a little note saying enough people are now in the room, so we are now officially quorate, just for information. So, looking for hands, real or virtual. Most people, okay, that didn't take long. So I'll hand over to Councillor Farhana Thomas.
Yes. Okay. Thanks very much, Chair. Thanks for your presentation. But just want to, in terms of the engagement, what we are expecting back from Hackney residents. It is good that this strategy is focusing on inequalities, and inequalities in the first place happen because of barrier, because of lack of equal opportunities. And I'm wondering, when you are looking at the questions in the survey, while the questions themselves are okay, it seems for somebody to be able to make to be able to answer those questions appropriately and contribute positively to the strategy, you first need to read the strategy itself. And I'm thinking from people who might be English as second language. And I'm not saying I know the answer to this, but I'm just thinking that there is a sort of actual barrier in people being able for a diverse members of our community to contribute to it in the first place. So I'm happy for other people to comment, not saying that I know what we meant to be doing, but reading it, it seems there is a sort of barrier that we are creating as well.
Before I bring it back, I've got a couple of hands up as well, so maybe we should just take a few comments first. Rosemary Jawara and then Councillor Carol Williams, both on the remote. Rosemary, over to you.
Thank you, Chair. I'd like to just pick up somewhat on the comment that was just made by our council. Thank you, Sarah, for a very good presentation. It's very enlightening. However, I'm just sort of coming into this event straight from the back of neighbourhood conversation that we had earlier today. And it was very lively, and it was attended by a number of different people, many of whom represented the community. And I say this because one of the things that really struck me as being imperative, and it chimes with what Councillor Farage was saying, and excuse me if I'm not pronouncing your name correctly, Councillor, it's not intended. However, it was around enablement and empowerment, because each of the three areas will clearly have a number of nuances that we need to, pick up on. We need to really sort of drill into that. And the person who brought that to the table is representative of people within communities who are, for example, carers in this instance, and have learning difficulties or disabilities. So this is, for me, a case in point whereby, and it really, as I said, chimes with what the comment that was made before, that the way in which the research and the engagement is conducted. I'm always talking about language and the way in which that is, the strategy is presented, so that people have every opportunity to be able to speak in their own way, find their own voice, to be able to contribute effectively to what it is that we're seeking to bring about. Thank you.
Thank you, Rosemary. I'll just bring in Carol Williams, Councillor Carol Williams, and then John, I'll come back to you in the next tranche of questions. So, Carol Williams.
Thank you. And thank you, Councillor Fajana Thomas, for your contribution. I think it's a really good question. But Sarah, I also recognise that you asked a question about who we should be engaging with. So I think those two are really aligned. We do need to, as Councillor Fajana Thomas has said, we do need to have easy read versions of any consultation document. And we also need to ensure that we are engaging people in any form or format they want to communicate through. I would hope that what we would be able to do is work with groups who have all sorts of impairments, whether that is visual impairments or hearing impairments, learning impairments, and other disabilities, other disabilities as well, so that they can, as Rosemary has said, use the form of communication that they are most comfortable with. And sometimes that will mean having a focused group specifically for a given demographic. And I think that it's also important that we don't leave out carers, particularly given the social isolation aspect. So for young carers as well, I think welcome an opportunity for them to participate in this as well, and give their feedback and their response to the consultation document.
Great, thank you. Three questions really around what next with the engagement and getting that right. So Sarah, over to you.
Thank you. These are really, really helpful points that we are thinking about. And I think we're really mindful of the fact that we want to make sure as many people can engage with this consultation, and that it isn't involving reading a 20-page long document. Shouldn't be the only way that someone can feed back, and it also shouldn't be just people who are accessing that online. We are working with colleagues at the moment and have raised the point around having an easy read version for people who might prefer that. We are trying to get paper copies I think we need to understand what would be involved for any translations. But I think one of the other points is building on that peer researcher model. What we really benefited from was that we had people who were part of their own communities who could speak to their friends and family, explain what was part of the engagement, and we'd like to replicate that through the consultation as well. So having people from different parts of Hackney, from different communities and backgrounds, being able to speak to their friends and family, perhaps, as you say, involving people through focus groups. As I know last time we had a focus group with older people, we had a focus group with people who were I think experiencing homelessness. So it's about making sure that we are finding ways to engage with people, and that can also involve setting up bespoke meetings. So we'll be making sure that consultation plan addresses those points. I was also keen just to say that during the engagement, we had some really good meetings with stakeholders who worked with people with special educational needs, with children. We had people who were working with people who had hearing loss and visual impairment. So we'll be going back to those organisations, for example, and saying, thank you very much for your input in the summer. Here's the draft of the strategy. We'd really love to know what you and your service users are thinking of this now. I know my colleague Donna has been working really hard on this as well, so if there's anything I've forgotten, then do say.
No, that's really good. We're meeting with comms this week, but wanted to just check in with the board first of all before we go ahead and develop the plan. But really mindful of your comments, and definitely will incorporate those.
Great, thank you. I've got 3 more hands, so I'll just keep going and then I'll make a couple of comments myself. So, John Williams, over to you. I'll take the 3 again and then respond.
Thanks,
John.
My question is about the consultation period from November to February. You're running it over December, which is always a challenging month. It's got the festive season in it, and it's a bit of a dead month to do consultations at the best of time. So I'm a bit concerned that you're actually limiting your time to actually 8 weeks as opposed to the full 12 weeks. So is there any flexibility on that, or has there been some thoughts about how you manage over a kind of quite a difficult consultation period?
Thanks, John. So Annie Gammon? Annie.
Thank you. I'm Annie Gammon, Director of Education. Just reflecting on wanting to get more young people involved. And I think we, in education and in social care, we've got a range of groups that meet with young people, or those who work with young people around mental health. And I probably won't go through them now, but what we could do is, if this is referred on to the Children in Education Group Directorate Senior Leadership Team, we can perhaps work with you to work out the best groups to use and how to take that forward. I also just wanted to ask a couple of questions about whether you're reaching out to the Turkish Kurdish community, and also whether there is, I suppose, flexibility of timing of some of the interactions, because I know that workshops during the working day don't work for a number of groups, including school teachers. So just that question. Thank you.
Thank you. And Helen Woodland. Well.
Thank you, Mark. So I wanted to say thank you to Sarah and colleagues for all the work, because I know this has been a mammoth task, and I think it's a really helpful piece of work for us to build on. Similar to Annie, we've got a lot of reference groups and co-production groups that specifically will work with a number of groups who have vulnerabilities or who may have communication needs. So more than happy to take this through those groups and to help explain it to them and get feedback through that route. The thing I wanted to question really was how this might link to our wider development work around the ICS, and how we link this strategy to other work that's going on. And whether we've got plans to do more general engagement with people who we might not normally talk to, and how we might do that.
Thanks, Helen. So I've got Councillor Bramble in the room, but I'm going to take those three now and back to Sarah, and then over to you, Sarah.
Thank you. So I think with regard to your question, John, about the timing, I know that one of the reasons why we have been pursuing this particular timeline is so that we could get the strategy kind of approved in the March 2022 Health and Wellbeing Board meeting, and therefore the 12 weeks running from November to February. Although I completely agree it takes that sort of December period in, I think if we were to make it a different period, we wouldn't be able to hit that deadline of getting the Health and Wellbeing Board cited on this and approving this in March. And I believe the intention behind that was that we would then be breaking for the pre-election period. So we didn't want to impact on that, as Dr. Husbands has just said in the chat as well. I also think, from my understanding of the last few months, there's no perfect time either. I know that when we were doing things over the summer, it was difficult because of summer holidays. When we were doing things in September, there were a lot of festivals for the Orthodox Jewish community. So we run into a bit of problematic times of the year, I think, throughout the year. So I think we may have to stick with the timeline that has been set, unfortunately. I think that sort of flexibility with timing that you brought up, Annie, absolutely. I know that we've been joining things in the evenings, and our peer researchers have also been doing things at sort of times when suits people. So we'll make sure we continue with that particular approach. And I really welcome all of the suggestions of people and groups we can speak to. We've been working really closely with groups all across Hackney, but we'd love to make sure we're engaging with as many as possible. I think that question around how this links to the ICS is a good one. I'm probably slightly underqualified to make all of the points that I think the ICS and its structures are obviously still working with our way through formation in some respects. In other respects, I think we'll be working with many of the same structures. We're going to engage with primary care networks and neighbourhood groups as well. But I think perhaps that question could be posed back to the Health and Wellbeing Board, just to make sure that we are making sure this is aligning with the work of the system. So hopefully I've covered all of the questions. I may have missed a bit. I was trying to make a note of everything.
Grand. Okay. Thanks. So we're going to go through another threesome. So starting with Councillor Bramble in the room.
Thank you, Chair. Just a brief point on the inequalities, and just reflecting on, as you know, that COVID has not just exacerbated the inequalities, but has made that even more challenging for groups that faced it challenging before, and those new people that are now known to us that weren't necessary. We need to think about how we're incorporating them, and thinking that maybe a new challenge that we have to consider that we wouldn't before would be the impacts of long COVID. Just the point around engaging with young people, Annie articulated that very well. What I would like to overlay, Chair, is that we've got things, for example, we've got Hackney Youth Parliament, we have Hackney Young Futures. They are talking about health, they are talking about the things that are important. I think it's really important that we incorporate what the dialogue that's already going on. Yeah, because we are at a new, exciting place talking about our strategy. We can't make the assumptions that the people that we are engaging with are at the same port of call. And it's going to be really frustrating if we go out to everybody and saying, we are doing this fantastic new thing. What do you think? We need to engage them and really hear what they've said and how we incorporate some of that around reshaping and also moving forward with our priorities. Thank you, Chair.
Thank you. So I'll just I'll take Sandra Husbands, which is nice to see you, Sandra, having given your apologies at the start of the meeting. So I'm glad you're actually able to make it.
Thank you, Chair. I'm not quite making it, which is why I'm not putting my camera on. I just wanted to come back on the point about the relationship of this strategy to the work of the Integrated Care Partnership. And although I don't have all of the complete answer, we are trying to work with the Integrated Care Partnership so that we are aligning the strategy, the actions with the work of the ICB. So we're not duplicating, but complementing. I don't know if Jonathan wants to add anything, but that's where we're up to at the moment, and ideally it will all come out in the wash next year.
Grand, thank you, Sandra. And Laura Sharp.
Thank you, Chair. I'm the Chief Executive of the GP Confederation, for those who don't know me. I really like this work. Well done, team. I find it very clear, and I'm very pleased to see how wide the thinking is, so that we are actually starting to take seriously the financial inequalities that people face and the impact upon health of things like poverty and low pay. So that we can start to think seriously about that. So well done. I also like the fact that you're trying to identify 2 or 3 things and stick with those, because we've got thousands of strategies with thousands of targets in them, and nobody can ever remember or what's going on about any of it. So focusing down on a few key things, however complicated they might be and however complex they might be in terms of the agencies that need to come together to work on them, is, I think, really helpful. I wanted to just push on the connection to the ICS a bit more. I think it is absolutely critical that we connect this work, and indeed the city health and wellbeing strategy work, into the Integrated Care Partnership Board's priorities for oversight, investment, holding to account. Otherwise, we won't. Otherwise, why are we doing it? Because at the end of the day, we've got to put some muscle and some clout behind what comes out of this 12 plus weeks hence. And the players around this table are the people with the muscle and the clout and the money. And that's why we need to be locked in and held to account around this. So that seems to me to be quite critical, and we probably need to do more thinking about that. We've got a perfect opportunity with some development time tomorrow for the Integrated Care Partnership Board. So it will be good to have in our minds the fact that these pieces of work for both City and Hackney are happening that need to drive our thinking beyond this particular health service or that particular institution into the broader population, health and wellbeing.
Thank you, Laurie. I absolutely agree with you. So before we go back to you, Sarah, I'm going to take one last comment from Jonathan McShane, and then over to you again, and then we'll need to move on.
Yeah, I was just going to really echo what Laura said. Unfortunately, the Integrated Care Partnership Board has just been set up, so the timing isn't exactly right for the ICPB to have developed its draft strategy and consult on it at the same time. I think in future years that would be a good thing to do. But given that this health and wellbeing strategy will be being approved in March, then hopefully the ICPB will be in a place where it's able to say what is the health and care contribution to the things that are being set out as priorities here, as well as the other things obviously that will be happening across health and social care. And then as we track progress as a health and wellbeing board and as an integrated care partnership board, I think just constantly, as Laura said, being making sure that these things are coherent. And I think there's a risk that the health and wellbeing strategy is doing good stuff over here and other people are doing good stuff over there. And if we're going to make the most of these opportunities, we need to make sure that those things are properly aligned.
Thanks, Jonathan. Sarah, and then I'll summarise.
Thank you. I think a few points that I've picked up is definitely around the alignment with existing work, which we're very keen to do. I think Councillor Bramble, you mentioned the work of the Youth Parliament and also of Hackney Young Futures Commission. We're trying to make sure that we're building on work that has been done. So we reference the Young Futures Commission report because they made points around mental health as an example. So we wanted to make sure this was taking into account things that people had said and that we could build on those. And we are, I believe, booked in to speak to the Youth Parliament for a second time in January, if my calendar's right. I think the alignment as well with the ICS and also with the city health and wellbeing strategy is definitely something we're mindful of. We're trying to make sure that where there is existing work that the ICS or the Integrated Care Partnership Board will be working on is woven into this. So one example is speaking to our colleagues at the CCG around the mental health joint strategy, which was in development and I understand is having its actions refreshed. So we're making sure that we're not starting from a blank sheet of paper, we're building on things that are in train already. And I think finally, in terms of tracking progress and making sure things are coherent, we'd really welcome involvement from across the Health and Wellbeing Board, but of course the health and care system in our task and finish groups to make sure that the action plans that are produced and the measures that are going to be used to track progress are really aligned, so that we're not measuring things twice, that we're not trying to duplicate reporting, and that essentially we've got an action plan that reflects actions that may be ongoing, but also the new things that we'd like to do as a result of this strategy. So thank you very much. That was really helpful feedback, and I am pleased that we've been able to get this draft over to you for today.
Thank you, Sarah. I can't help thinking it's really good work, and you know, to be congratulated on your team as well with how far you've got with it. I can't help thinking that the work just becomes more and more challenging as you proceed to really make it real. And in terms of clearly prioritising certain things is important, but you do point out there's an awful lot of other work that will continue nonetheless elsewhere. I think that in terms of what we were asked to consider as the board, I think there's been no doubt that we've spent quite a lot of time considering the draft consultation, not specifically the questions, but the approach and who needs to be involved and how best to engage and consult. I'm sure we will all try and promote that process as best we can in our different ways. But the other thing we need to do as a board is to approve the draft strategy and that we wish it to be then proceed to be published and the consultation process to proceed. So I just want to hear some indication from the board that they're happy for us to agree that should happen. Agreed. Thank you. A few nods, agrees, quite a few nods. Right, thank you very much, Sarah. Great, thank you. So let's move on then to the Joint Strategic Needs Assessment update. So Diana Divajeva is going to present that process for City and Hackney, the process. Diana, I'd maybe speak for about 10 minutes, then we'll have about 10 minutes for discussion as well. And I know that we're being asked as a board to approve the new process and contribute to the annual JSNA work plan, as you will describe, and actually advise on the best time to initiate the annual JSNA process as well. But anyway, I'll reflect on those at the end of the discussion again. So over to you.
Many thanks, Chair, and good evening, everybody. My name is Diana Divajeva, and I lead on the Public Health Intelligence in City and Hackney. And today I will be presenting to you the reworked JSNA process, just like the Chair has announced just now. By way of reminder, at the last Health and Wellbeing Board meeting, I took you through the Public Health Intelligence strategy and the key principles that are used to inform the strategy. And these include, number one, that we shift the focus and the workload away from data processing and describing to generating insight that can be actioned and will result in providing value to our organization and residents. So actionable insight, providing value. And number two, empowering colleagues and the public to understand and interpret information by simplifying the language, providing easy and timely access to information and support them in improving their health literacy. Number three was to ensure good information governance standards are upheld, and by doing so, to increase our residents' trust in our handling of their data so that we can provide them with the best possible services. And lastly, to improve on our communication, collaboration, and aligning of our work with the key strategies, policies, research, and commissioning. And that's not just in Hackney, but across the whole system. So the Joint Strategic Needs Assessment process that I will be describing today is based on these principles, and you will note them throughout the presentation. In your document packs, you will have the presentation itself, but I will also share my screen. Just because it always makes it easier to follow through the slides. Could you please let me know if you can see my screen? Anyone?
Not yet, Diana.
No, not yet.
Sorry about that. Just try again. Did that work?
Yep.
Yep. Sorry. Just gonna go back. Okay. Right. So the outline of today's presentation is the purpose and the format of the GSNA, then the process, and just really a light touch on the outputs in the form of the website. The purpose and the format of the GSNA you'd be familiar with. So Joint Strategic Needs Assessment is an ongoing process. So it's not a report or a set of reports. Rather, it's a process that keeps repeating itself depending on the needs. And it should help us to identify the health and well-being needs of the local population. It's a statutory requirement for us to produce it, and local authorities and clinical commissioning groups have equal and joint duties to prepare the GSNA. The core aim of it is to develop evidence-based priorities so that we can improve the public's health and reduce health inequalities. And it's quite broad in nature because our health is determined by a range of factors, so the GSNA topics also range quite widely. For the GSNA to be fit for purpose, colleagues from across the system need to have their specialist input into it because nobody knows everything about every single topic. And when done well and in a timely manner, GSNA will inform and underpin the key strategies and other local plans that seek to improve health of our residents. So what goes into needs assessment and what comes out? So what's the input, what's the output? GSNAs draw on a range of resources, historically perhaps more quantitative heavy, so data heavy. So I'm proposing that moving forward, Joint Strategic Needs Assessment outputs or reports or needs assessment include the following components, maybe not every single one, but just considering all of these. So intelligence sources like quantitative data from our data sets, from our dashboards, internal and external, qualitative elements, so insight that our community work provides to us, our community champions, peer researchers, and volunteer community sector, relevant strategy and policy documents, whether local, regional, or national, and that's to provide the context. And often these documents also include evidence reviews, which just then make the whole process more efficient for us to include something that's already been done by somebody else. Behavioral insights, we have incorporated these into our COVID response quite successfully, and there is no reason why we could not continue with the needs assessments in the future for other topics as well. And academic literature, that's a standard component of a needs assessment, and that's just reviewing what's been done in other areas and what's been successful, and if there is any other evidence that we'd like to include into our evidence base when we write up our needs assessment and come up with recommendations. As outputs for the GSNA previously, we would have a large report on a topic, would be quite lengthy, very broad. So one of the key changes that I propose is that we use a range of outputs as our evidence base, forming the Joint Strategic Needs Assessment. So it could be short topical reports. So for instance, there might be one research question that needs answering, and that would be that. Detailed needs assessment, so sort of similar to what we've done before, but I will go through the process just in a minute to describe how that will be different yet. And interactive population health profiles, and that's something forming, again, the evidence base, something that has both public and secure sites, so similarly to and learning from our COVID work. So some of the information relating COVID is public, some of it is just for the eyes of the policymakers and people who are working on service design. So similarly, interactive population health profiles fitting those both purposes, so public facing and forming our internal evidence base. And I have links to various guides throughout this presentation, and that's at the end of the presentation as well. And that just includes the proposed template and structure, as well as some other resources that I will touch on throughout the presentation. In terms of process itself, I have spent quite a few months thinking about it, and I think if we're to have successfully implemented health and all policies, we really need to make sure that we plan really well what we're going to do in terms of the needs assessment throughout the year, and maybe even have a longer term plan. Having a set work plan and thought through work plan provides many benefits, including better alignment with upcoming strategic work and major projects, better management of staff time and capacity, because that's quite important. We don't have an infinite capacity in the system, and improved communication, so ensuring that we're learning from what we've done and learning successfully and exchange information across the system, so that we don't duplicate the effort and we have a bigger impact on health of our residents, positive impact, of course. And another key change to the process is that hypothesis-driven research. So rather than trying to describe everything that we know about something, we start with a question or a set of questions. So we already know things about things. What is the question that we're seeking to answer with this particular needs assessment, or with this research that will inform our service commissioning or our strategy or our policy? This is one page describing the process itself. The following few slides describe this in more detail, but I won't go through them. That's very operational, and that's for your information only. So I will just talk you through what you see on this slide right now. There are 4 stages to the proposed process. Initiation, that's where in the beginning of the year we go to steering group meetings, working group meetings, board meetings, any key meetings where partners across the system might feed into that work plan that then we pull together for the whole year. And we prioritize, so the essential needs assessment will be those that support policy, strategy and commissioning. So these will be given priority, but then if there are any other requests for reports, research projects, needs assessment, that could also be submitted to us, and we'll consider them. If there are very many, and there's definitely a sense that we won't have the capacity to fulfill all of these requests, then I've also pulled together a very clear and transparent selection process, so how we're going to prioritize different projects based on a set criteria. At a second stage of approval, so step 1 will be the list of projects is finalized by the senior public health management team. Then that same list is brought to the Integrated Care Partnership Board, just to make sure that we've taken into account everything and there are no gaps. And lastly, the list is brought for approval to the Health and Wellbeing Board. And then once approved, then it just, again, increases transparency, and it's quite clear to colleagues and the public what we're going to be busy with for the year and what our outputs will be at the end of the year. At the production stage, we allocate the project sponsor, we allocate the lead and the delivery team, and then it just describes how the whole process of pulling together the draft is going to happen. And lastly, with the dissemination and evaluation, another key change I propose is that we engage in active dissemination of the findings. Again, that's to make sure that people who are interested in that subject, in that topic, they are cited of the recommendations that come out through the needs assessment and through other work. Because often if it's just emailed and said the report has been published, it is possible that things have been missed out. And again, this is about exchange of information and exchange of those recommendations, and as well making sure that recommendations are acted upon. So recommendations then are actions by the project sponsor, and another change to the process is that we will be asking the project sponsor to provide us with an evaluation after some time has passed, after the project has been completed, and unless it's specified, it's not a formal evaluation, but rather, again, it's a set of questions that we'll be asking for the project sponsor to answer, and the findings could also be brought back to the Health and Wellbeing Board. So we, again, perpetuate that learning, and we are quite honest with things that don't work, and we do less of those, and with things that work, and we maybe scale those up. So that's really quickly about the process itself. And like I said, these slides just define just talk through.
Diana, I'm just going to cut in a little bit because I'm glad you're skipping over those ones, because obviously that elaborates on what you've said. Just a brief, I mean, I was in the paper and you presumably going to mention just how you disseminate the website piece. Do you want to just tell us briefly that, so we've got enough time to take some comments and questions?
I'm on it. So yeah, I've just gone to that section. So in terms of websites, it's quite crucial that we've got one source of truth, evidence base, and the proposed changes to the website are outlined on this slide here. Just not to go into too much technical detail, it's making sure that people understand what the Joint Strategic Needs Assessment is about, and introducing the reader into the 4-pillar framework, because we're using that throughout the health and wellbeing strategy, and I suggest we also use that to combine the reports into themes as described in the population health bit right here. And we have that interactive component here where people can see the key socio-demographics and key population profiles for City and Hackney. And we will be working towards also having ward profiles, because these kind of statistics are the most in demand. And there are different sources of information out there. We would like to have, like I said, one source of truth, so that there is no ambiguity there. And this is the trusted side of data and information. And we have all of the evidence base in terms of needs assessment, research projects, any links to external or internal documentations that are relevant on this website as well within this section. And people can easily search the reports and filter them through if they want to find evidence quickly without going into too much detail into any of these pages. So that's it. And like I said, there's some supplementary material outlining the structure, proposed structure, a prioritization criteria for the projects that might be not quite fitting into the essential category, the initiation document format. That's something to be thinking through before even beginning a needs assessment. And that's quite important, because it just helps to refine the questions and making sure that the project is fit for purpose and that the purpose is quite clear. And then criteria for reviewing drafts and those evaluation questions that I mentioned, making sure that we also track the impact of the work that we do. And that's it. So I'm going to stop sharing that.
Yeah, thank you very much. That's really comprehensive. And I know there's a lot more detail you could go into, but thank you for summarizing in that way. I'm just one hand's up already. I mean, certainly thing that I was going to say just briefly is that I'm sure the strategic needs, the strategy will be making plenty of calls on needs assessment work. I'm sure they already are, and that's presumably is what you're expecting to receive. Of needs assessments and the outputs you described, short topic reports, detailed assessments, and population health profiles to support the strategy. So, I mean, just reassuring us all that everything is going to be linked up in that way. It slightly comes back to when you undertake the work. It seems to me the work is being undertaken now already.
Shall I invite Alexander to?
Yeah, actually, seeing it, I've seen Malcolm's hand up. Let's take Malcolm's question as well, and you made comment about how much work is actually going on within this process, how much it's actually started. Let's take Malcolm's question first.
Okay, thank you. Thank you very much for that. I just wanted to understand a bit more about the impact of the JSNA on local communities. Do we have evidence from previous years about how the JSNA has impacted, had made improvements in terms of the services that local people are providing, and also whether this impacts on the previous work that we've been talking about, but in relation to health inequalities, for example. Is there evidence base produced every year that because I don't recall seeing one from previous year?
I can take that. So that's why I'm proposing this process. Like you've just heard, we previously didn't have any systematic way of pulling that evidence together. So what works, what doesn't, and that's why that's one of the key components now of the GSNA process. So that evaluation bit, making sure that we do more of what works and less of what doesn't.
Okay, can I take Chris Kennedy's question from the room?
Thank you, Chair. It would be remiss of us on NET Cancer Day, Neuroendocrinal Tumour Day, not to ask, I think, that the population health profiles, and I think the ward profiles, highlight at least that you're more likely, if you die of cancer, to die from a rare or less common cancer than you are from one of the big four. And perhaps it might be the subject of one of the individual topic reports. Thank you.
Diana, I'm just going to take another question from Susan Masters, again in the room. You need to. We can't hear you.
Oh, fantastic. Thank you very much. Sorry about that. This is my first meeting and I'm here from Hackney CVS. At the moment, we're unpacking the findings of our VCS assembly on how we make Hackney and City anti-racist. And one of the themes that's come through is a real hunger for the kind of data that you get from a joint strategic needs assessment. In particular, some of the areas that people are interested in finding out more about are more details around ethnicity and long-term conditions, unemployment, exclusions, and also sort of barriers to exercise. So I don't know whether there's a way in sort of working on the new website that you can sort of work with us to help sort of answer some of these questions from our voluntary sector organisations.
Thank you. Diana, do you want to come back on those questions?
Yes, so Councillor Kennedy's question, that is why I have described the process as I did. So if we, at the beginning of the year, we take stock of what is the key kind of questions we want to answer this coming year. So what is the priorities for us? Health and Wellbeing Board agrees that rare cancers would be one of them. We then kick off that process and that needs assessment. So the answer is yes, we can definitely write a needs assessment about that, as long as that's agreed within all of the working groups that that's a priority, and Health and Wellbeing Board approves that as a part of the work plan. Again, thinking about alignment with all other policies and strategies. So what I guess, I don't know if I relay that really clearly, but what I was trying to say is needs assessments should not be done just because it's interesting to look at something, but for instance, we're planning a service, or we see clear gaps in services, or we see clear inequalities, we want to do something about it, and ethically we will be doing something about it with that information. So that's when we do it, because we have capacity, we know we can do this, we just want a little bit of steer of how to, so what the recommendations that will come out from that needs assessment. So aligning that with all of the other work that goes on in the borough and across the system. About the second question, so we, like I mentioned, we will start with the key population statistics and we will build slowly. Reason being is we are still in business continuity, because we're still, like a large chunk of our work still dedicated to COVID response, and I only have a tiny team, but I will I'll be working with colleagues in the data and insights in Hackney ICT, and we'll try to pull together resources to be producing those interactive profiles as soon as we can. So we already kicked off that work. It's just now finding time and capacity within the team itself to do that. But yes, it's in the plan. We already started. So the website, you will start seeing changes to it quite soon. And then once the profile is developed and we've quality assured them they're working, they're showing what they're supposed to, then that will be published, and we will be communicating that to all of the stakeholders.
Great, thanks, Diana. I'm going to leave the last question to Councillor Carol Williams, and then we better summarise and move on.
Thank you, Chair. It was just a follow-up to the contribution from Councillor Kennedy and Diana's response. And I guess my pushback would be, given what Councillor Kennedy had said about cancer deaths and outcomes for rare and uncommon cancers, I would have thought that there is an ethical argument for why we need to have a basis for understanding that the impact for Hackney residents, particularly if that's not data and information that we currently have, taken together with the pandemic and the impact of services throughout the course of the pandemic and cancer treatments. I think that would be another argument for why that is something we would want to do, certainly in the next few years, to understand the impact not just for the big four, but also for rare and uncommon cancers.
Great. Thanks, Councillor Williams. Diana, I'm not sure that you need to respond particularly to that because it's a sort of follow-up comment, really. Just to summarise, I guess we've been asked as a board to approve this new process. Are we minded to do so? If you are, can you? Yep, nods. Could I have a few nods online? Thank you. And also contribute to the annual JSNA work plan as described, but that will obviously be an ongoing piece of as the work unfolds. And advise on the best time to initiate the annual JSNA process. I wasn't quite sure what the ask was there.
Yeah,
can you just explain?
To clarify, because there are commissioning cycles, there are political cycles throughout the year. So my question was, what would be the best time for us to kind of kick off with asking stakeholders about, so this year, what are your priorities for the year, and do you need any help? Do you need us to assist you with assessing the needs, or do you have a research project in mind? I know in other councils they initiate around autumn time, just before Christmas break, so that they can finalize in January and then start working on the needs assessments from around February, March time. And then that's their cycle, that's the annual cycle. So I was wondering for Hackney specifically, what kind of timings would work best with all the other cycles that I've mentioned?
Well, what do people think? It's a cyclical process. Laura Sharp, do you have a comment about
that? I think this is quite tricky because we need to lock it into the planning cycles for the new ICS structures as well, so that we get the best out of the entire process from start to finish and beyond. And I don't think we entirely understand those cycles yet. So I guess my plea would be, if it is possible, I'm presuming that you're saying, Diana, that you are kicking off this year now after this meeting. So we have got a bit of time to think about this cycle for beyond. If you can bear with us for a bit longer, because I think it is really important that we knot these things together as much as we possibly can. I mean, I don't think we should leave it too long, because obviously it's a big piece of work and needs to be planned into people's work programmes. But I think if it is possible for us not to decide that just yet, so that we can be a bit clearer about how the rest of the decision-making infrastructure lands, that might be of use.
I think that seems eminently sensible, and I think looking at What Sandra Husband's also put in the chat as well, take the question away and come back to us when we have more clarity about some of those other, how we fit in with the general rhythms of work we have to be aligned with. But in the meantime, it's supporting the work of the health and wellbeing strategy is obviously clearly important, but that's going to be an ongoing piece of work anyway. So would that be, you asked for our advice, I guess that would be as far as it could go at the moment.
That's fine. So would it be possible then at the next Health and Wellbeing Board meeting to have a bit more, if it's supposed to have a bit more clarity on that? Yeah, that's good. And it's more than that way. It's not just the health and wellbeing strategy. There's already quite a few things in the pipeline for the team.
And as Sandra says, it's an iterative process. So you know that we can shape this as we go forward. Okay, thanks everyone. Thank you. Thanks, Dina. Rosemary Joara, do you want to have a quick last comment because we do need to move on now? Rosemary, are you on mute? We're not hearing you. I think you might have an IT problem, Rosemary. We can just see a little circle with you in a jaunty hat. But we can't hear from you. All right, I think we'll have to move on. I'm sorry, Rosemary. So let's move on then.
Mark, I think you're on mute.
I've just been talking and no one could hear me. Sorry. I was just going to call on Andrew Trathan to present the item on the pharmaceutical needs assessment, the update for the City and Hackney assessment. And there's a number of things which are being asked as a board: note the process, receive the terms of reference that he's going to present, to agree the delegation of the final sign-off of the draft is given to that steering group. But anyway, I don't want to dwell too long on the asks. We'll check we've done that when we come back to at the end. So, Andrew, over to you. You've got a sort of 10-minute max presentation, and we'll take 5 minutes for some questions.
Certainly, I don't anticipate needing all that time. I think the report speaks for itself, and I have relatively little to add. It is quite early in the process, but just as means of a quick summary, pharmaceutical needs assessments are statutory requirements of health and wellbeing boards, needing to be produced every 3 years. Ours is due in October 22, which is a little delayed because of COVID, but that's been an extension has been permitted through the regulations. We have commissioned Sorbeyond, a provider with a great deal of experience in producing these P&As, to take us through the process. And we've assembled a steering group to see this through. And that steering group has now met once. As of now, we are working through the final logistics of launching the engagement phase, which we hope to send out to the public, commissioners, GPs and providers next week. And that will run for a month or so. I think all the other relevant information is contained in the report. As I say, it is quite early at this point, so things are somewhat of a formality at this stage, although I'm happy to answer any questions. As discussed, we're asking the board to note the contents of this update, but importantly to approve delegation of authority to the steering group to produce both the first draft and run the consultation and the final draft. So back to you, Dr. Ricketts, to marshal any discussion.
Okay, thank you very much. So on the paper, obviously, it describes the terms of reference. Do we have any comments or questions on that? Andrew, were you seeking any particular points of advice or clarification from us today, or are you hoping that we just say, great, go for it?
More the latter than the former. I'm very happy to take on any comments or questions if anybody does have any. but otherwise really seeking that delegated authority. That's key at the moment.
Well, I don't see any hands. I'll just check the chat in case anyone's being a little shy. No, so no further comments on this item there. So therefore, Andrew, I think I haven't got any specific points to make either. So I guess we've noted the report in the papers and received your terms of reference. You've given us a sort of outline of the project plan, timelines, etc. And from the, well, I'll check, but I think we agreed to formally delegate, sign off the draft of final pharmaceutical needs assessment to your steering group. So is everyone happy with that? Yeah, a few nods. Thank you. Okay, we're happy. Thank you, Andrew.
Thank you very much.
So we move on to the City and Hackney Safeguarding Board annual report. Rena Griffiths and Dr. Addy Cooper are both here in the room. You're going to present the report. I guess questions for us to consider is which priorities and emerging issues are overlapping with the Health and Wellbeing Board agenda, and how can both boards continue to work collaboratively going forward. But there's a lot in your report. I know there's some key bullet point headlines that you're going to bring out. So I guess we've got a little more time because the previous item was pretty quick. So I would say you've got at least 10, 15 minutes to present.
Thank you, Chair. So there are some slides that capture some of the key messages from this year's annual report. So I'm Dr. Addy Cooper. I'm the independent chair of the City and Hackney Safeguarding Adults Board. Can people hear me okay? Yep. So I was going to look at the progress that we've made in this last year and our priorities, mention a few safeguarding issues, and use the opportunity of presenting today to identify whether there are any areas of joint interest that we might take forward working in partnership. So firstly, looking at this last year, which has been very challenging, and I'll start with the second point really, which is the response to COVID and the impact of COVID on all partners, which we've been continuing to monitor through meetings of the executive of the Safeguarding Adult Board throughout the whole of last year, ensuring that partners were maintaining their adult safeguarding duties and responsibilities despite the unprecedented challenges faced because of the pandemic. And I think there was considerable assurance that that was the case, and people responded incredibly positively to maintaining a perspective and continuing to keep people safe. But obviously there are longer term impacts of COVID in terms of safeguarding activity, and that is not over, not least the pandemic isn't over, but also the impact in terms of risks for safeguarding. We've also managed to continue to sustain on behalf of the three partnerships, so the Children's Safeguarding Partnership, the Adult Safeguarding Adult Board, and the Community Safety Partnership. I chair on behalf of the three boards a piece of joint work on transitional safeguarding, so that's safeguarding younger people moving into adulthood from the specific risks that they face in terms of that age group, in terms of safeguarding needs and risks. We've completed the first phase of the work, which looked very much on engagement and scoping the areas of what people were identifying were their safeguarding needs, and we've moved on to a second phase in terms of an action plan looking at seeking assurances from people working with young people about their safeguarding, identifying safeguarding needs, and increasing awareness and support for younger adults and their safeguarding needs. We've also continued to meet our statutory responsibilities on safeguarding adult reviews. So we have three key statutory responsibilities, and undertaking safeguarding adult reviews is one of those. There were two that I'll draw attention to this evening. One was MSR. People might remember the man who was sleeping rough in a bus shelter in Stoke Newington, who died. And that was a very thorough and complex piece of work that revealed a whole number of themes around how people who are rough sleeping are excluded, whether their safeguarding needs are recognised, how they're responded to, issues around self-neglect, substance misuse, assessing mental capacity, and there's an action plan that's been developed and a hugely positive response in terms of actions taken by partners to improve their response to people who sleep rough, who have safeguarding needs in terms of social work intervention, housing benefits needs, including the social workers in their outreach teams, and the pathways to the different high-risk panels having been reviewed to make sure people don't slip through the net in terms of working with people who maybe don't want to engage with services in the way that we might want them to, but we have a responsibility to keep safe. That's ongoing learning, and we've been monitoring it through this year. It's not finished. I think there's still ongoing learning, particularly as the pandemic responses to the lockdown move on and the needs of people sleeping on the streets change. The second safeguarding adult review that was published during the year was a fire death, and we were fortunate in bringing back somebody who had reviewed a previous fire death in Hackney. So we were trying to understand not just the specific circumstances, in this case, the gentleman who died in a house fire, but why and what hadn't we learned or hadn't we managed to embed from previous learning? Because I think one of the frustrations, certainly in terms of safeguarding adult reviews, is trying to get that learning embedded so that we're trying to prevent future similar deaths happening. The result of that has been reviewing how we look at our self-neglect and hoarding policy, and I suppose revitalised input in terms of safety, fire safety work, in terms of reminding residents around their smoke alarms and systems, and working better with the fire safety services, supporting carers, particularly because that was an issue that arose in this case, trying to revisit fire safety as a safeguarding area. So again, the learning from that is an ongoing piece of work that we're reviewing and evaluating its impact. So moving on from safeguarding adult reviews, looking at our priorities for this year, we've gone a bit back to basics. So we're looking at ensuring that core safeguarding adults is in place, looking at how well agencies deliver their core duties around safeguarding as we move out of the sort of lockdown stages of the pandemic, where there have been underlying increases in referrals and safeguarding activity, particularly as the lockdowns ease. There's a national and local picture of increased safeguarding activity. Partly with the learning from the death of MS, looking at raising awareness of how people assess and respond to issues around executive mental capacity, particularly around self-neglect and hoarding, and how we escalate issues where there are very complex cases, complex needs, and people maybe aren't sure about how to respond most appropriately. As I said earlier, we're continuing to work on transitional safeguarding and trying to continue to raise awareness of improving support to young adults who may be at risk. And then another area we're looking at is digital safety and exploring how we might be able to support residents to use online services safely and manage the risks around online. I think there's been a lot of work done on children's services and through the children's partnerships on this, but much less work done with vulnerable adults around safeguarding risks and online services. So moving on in terms of emerging issues, when I presented the annual report last year to the Community Safety Board, members actually raised issues about antisocial behaviour and the interface between antisocial behaviour and safeguarding adults. And so we've been doing some work around that in collaboration with colleagues across other areas of service, looking at a range of behaviour issues, including mental health, issues about victims and perpetrators, looking at a focus on cuckooing, which again has, I think it would be fair to say, escalated somewhat in terms of the pandemic, cases of people whose premises are being abused and they're being abused in terms of their vulnerability, and also self-neglect. So this area requires a really quite comprehensive multi-agency response, and not all of them fit sort of neatly in a traditional safeguarding adult remit. So we've got a task and finish group with a wider group of partners trying to explore and address those issues. And then also an emerging issue around intergenerational domestic abuse, which I don't think is unique to City and Hackney, and certainly has increased during the pandemic, which is about abuse within families, for example, adult children with their parents, elderly parents. And I think it's about raising awareness of particularly older people as victims of domestic abuse, not necessarily in the traditional intimate relationship paradigm that most people think about when they think about domestic abuse. So looking at work around this, the protocol's been drafted on intergenerational domestic abuse to try and raise awareness, and we're using that as a mechanism to try and support people to work better in this particular area of work. So I think finally, coming back to your questions that you raised at the beginning, I'm interested to see what of our priorities or issues may overlap with work that this board is doing, and whether there are not any opportunities to work collaboratively going forward. Of course, I'm happy to answer any questions on the report itself as well, and take this opportunity for colleagues to raise that here.
Great, thank you very much. I mean, it's a tour de force just to present it so succinctly when there's such a rich report, which I thought was really terrific. I really enjoyed the report. It just illustrates, I think, well, the quality of the work. So thank you for that. Just to see if our hands are going up. Oh, okay, Rosemary Chawara.
Thank you, Chair. I've been having some technical issues, so I'll try and be quick before I get frozen out again. But, you know, this is a very alarming report, and certainly sort of resonates with the kind of work, the kind of circumstances, situations that are continually presenting within the community. And I take this opportunity to say that this is a case in point where the VCS needs to be, you know, sort of an opportunity to work more collectively with the VCS. As a small charity, I personally have been supporting people who, for example, are going through kidney dialysis 3 days a week, experiencing food poverty, fuel poverty, low income. It's got to the stage where I actually, from my own pocket, and I'm quite happy to do this, buy food or deliver food to these people, because when I heard the report of one resident, one patient who, for example, was saying that he exists on the biscuits that are provided, you know, when he attends dialysis, which, you know, nearly broke me, because this is someone who is experiencing kidney failure, but doesn't have the support measures in place to be supported through this particular stage of deteriorating health. And so I think the evidence speaks for itself that, yes, again, I'd like to reiterate how, you know, vital it is that there's much more collaborative working with the VCS, grassroots organisations and small charities. Thank you very much.
Yes, please respond.
Thank you for that. I think we try very hard through the Safeguarding Adults Board to work with the voluntary and community sector in whatever ways we can. And we have, for example, in previous years promoted safeguarding champions within the voluntary sector to make sure that safeguarding issues are properly understood and raised. So I really welcome any opportunity working across with the CVS. I think in terms of the impact of poverty, we're definitely seeing that through the safeguarding lens and through cases that are coming through in recent months, I think, from at a sort of a national level, but obviously you're experience directly reinforces that message of understanding the risks that people are facing and being able to signpost people to the right support to enable them to get help in the right ways. So thank you for that, and thank you for that encouragement and support for joint working.
Thank you.
Chris Kennedy.
Thank you as ever, Adi, for a very comprehensive report on the work you're doing. I think the biggest sort of overlap with the emerging health and wellbeing strategy will be the work on social isolation. And I think there will be an opportunity in the action plan, I think, to identify ways in which we as a health and wellbeing board will work with you as a safeguarding adults board to help address some of the issues that have just been highlighted by Rosemary. Thank you.
No, I was going to mention that as well. It seems to shout out in a way from what we've been talking about earlier. But indeed, of course, the other two priorities, the improved mental health and mental well-being, and clearly you've already mentioned poverty. So I think it's just a matter of making sure that you are linked into the appropriate working groups as we move on. You know, if you don't feel you are, letting us know. But I'm sure you will be.
Thank you. I think we'd really welcome that opportunity to do some joint work around all these areas. Certainly, the data shows that the impact of COVID and social and the lockdowns on social isolation, mental ill health has a direct relationship to the increase in safeguarding adults' activity over this last 18 months, and that's at a national, regional and local level. And so anything that we can do in terms of working across boards to promote and support activity in that area is really welcome. So obviously outside of this meeting, we can look at how the board can engage with the work streams in the Health and Wellbeing Board, what's most appropriate.
No, I agree. And, you know, the issues that are raised in the report are so important. To address them as effectively as we possibly can is, you know, clearly a high priority. So thank you. I can't see any more hands. Oh, yes, I can. A real hand, Susan.
Thank you. I was very interested in your focus on cuckooing, which is a huge issue. I'm really pleased you set up a task and finished to look at this. And I'm aware that, you know, work's still underway, but I'm just wondering if you've got any early ideas about best practice in dealing with this problem.
Can I ask Raina, who's the practice manager, manager for the Safeguarding Adult Board, to respond?
Yeah, so I think it's definitely the case it's an emergent issue in terms of safeguarding. So there's not loads of work out there about how you respond to that in a practical way. We have been engaging with our national boards to look at how we can get a best practice response. Certainly we've got a 7-minute briefing we'll be bringing out next week in line with Safeguarding Adults Week, and that gives some tips about some practical things we can do just around making sure people are aware of cuckooing, because I think that's the first step really. You know, this isn't something it's not a new phenomenon, it's been going on for a long time, and I think getting people to understand what it looks like is a good first step in tackling it, and also understanding what people can do when it arises is really important as well, particularly I think for housing teams and housing associations where we perhaps do see cuckooing happening quite a lot. So I think that's definitely an area of focus, and then how we can work collaboratively to approach it and looking at, you know, people who are experiencing it and understanding their links in terms of having care and support needs is really important, because obviously a lot of people that might come in and be referred in might not be considered to have care and support needs. We just need to make sure there is approach there to support people who are experiencing it and look at how we can approach it in a wider remit, looking at which other organisations play a really instrumental role in responding to it.
Thank you very much. Okay, I can't see any more hands, so I think we should move on. I know we were asked to sort of be discursive and note the report rather than to approve of anything. So thank you, both of you, and thank you for your work. So I will move us on then to the Substance Misuse ADA Place-Based Accelerator update. Simon Young is going to present an update really for the board to note the report and the progress made. And I know that Sean Lyons over there has been sat patiently as well, maybe contributing to this item too. But I'll hand over to, well, either of you to present the report.
Thank you, Chair. Good evening, all. I'm very much aware I've got the illustrious task of presenting, I believe, the last paper of the evening. So I'll err on the side of brevity. But what we wanted to do is bring a paper to you all, as the Chair has said, to make sure that there is an understanding and oversight of some of the developments that we've seen across the substance misuse work streams over the past sort of 5-6 months. A little bit of context, so outlined in the introduction, central government, so 2 central government departments, PHE, as they were at the time, now OHIT, and the Office of Health Inequality and Disparities, alongside the Home Office, decided that they wanted to do something to tackle very high drug deaths across the nation, and also very high levels of criminality related to substance misuse. With that in mind, they created the ADDA initiative, so the Addiction, Diversion, Disruption, Enforcement and Recovery Initiative, which I forget the actual what it stands for half the time, so I'm very glad I didn't forget it this evening. But the idea there was to pump some funding through into local authority public health teams to help increase health-related outcomes and to ensure that those levels of drug deaths were able to diminish, as well as pumping some funding into enforcement partners and police partners. That was seen to be going quite well, so they decided on a second tranche of funding, which they dubbed the ADDA Accelerator sites in sort of early 2021. Hackney, alongside Tower Hamlets and the BCU, so the Borough Command Unit, the Metropolitan Police team that covers both Hackney and Tower Hamlets, were selected as an area who were indicating very high levels of drug death in comparison to similar areas, and so we were awarded funding. We reach awarded around about £1 million. In actuality, we received £900,000 in the London Borough of Hackney. And since the initial year's worth of funding was agreed, that was extended to 2 years. So we're looking at around about £1.8 million worth of funding across 2 financial years. In order to use that money as wisely as possible, there are sort of 3 broad areas that we've targeted the funding at. The first is increasing the amount of provision that we have available already within our substance misuse structures and provisions. So we expanded our criminal justice recovery service. That's received a few new members of staff, as well as some additional coordination. We've expanded the psychological input that our services are able to have through our commission provided Turning Point. We've embedded things like forensic psychologists, working towards getting non-medical prescribers embedded in the team to ensure that people have access to opiate maintenance therapies and those sorts of things. Alongside that, we identified through a series of consultations with stakeholders that we weren't necessarily reflective of the population who needed substance misuse support within the borough. So we brought online some more diversity sensitive related services, one of which is an organisation called SWIM, who are delivering what is called their PACT programme, which is aimed at working with older black men who are involved in both substance misuse and the criminal justice system. And we've also brought somebody who is working for an organisation called London Friend, which is an LGBTQ+ specific organisation, to help ensure that when our substance misuse services are working with people who identify as being a member of the LGBTQ+ community, they are receiving safe support, which is understanding of their distinct substance misuse needs and some of the criminality which is related to those substance misuse needs. Skipping through that, we're then thinking about some of the strategic oversight that we've also been able to implement and develop centrally within the authority. So my role is funded by ADDA Accelerator monies. I came online in June. I'm the health systems coordinator, and my remit is to, one, make sure that everything that we've got funded, which is being funneled through to our commission services, is operative and delivering effectively, but to also help working with the principal public health specialist who oversees our general substance misuse contracts to ensure that our system is delivering against some sort of core key aims which will help us get towards that reducing drug death figure. We also then have a criminal justice coordinator who has just come into post in the last 2 weeks, who will help with the interface between criminal justice services and substance misuse support services, predominantly working with some of the probation teams to make sure that we're enacting some of the learning from the recent CQC and probationary inspectorate report into how probation workers can have more effective relationships with individuals who they are overseeing, as well as them working alongside our partners a little bit more in the Met and with street enforcement officers and the community safety team as well. Moving on from that, and I think a really interesting story to tell through this paper is the data which I've put in place, and I just have to scroll through, and my computer's running relatively slowly, which is great. But I think there's a set of data which indicates some of the things that we definitely need to be doing within the borough to try and tackle both that kind of related drug death and that criminality, which springboards off of substance misuse. So the first piece of data is looking at the yearly death rates. So I've provided with you on page 6 just a quick overlay of the figures of deaths related to people who are connected to our substance misuse services, on top of the Office of National Statistics annual death rates which they've put forward. As you can see, there's a huge disparity there. Ultimately, people who are engaged in treatment services are not necessarily the people that we're seeing who are dying related to their drug misuse and related to drug poisoning. I've actually qualified that a little further as well by explaining, as part of our death in treatment panel, the predominant number of deaths that we see aren't actually related to the individual substance misuse. So it's not through drug poisoning, and it is unlikely that it would have been recorded on the coroner's report that they died in relation to their drug usage. We are seeing other causes of death. So in actuality, there really is an indication that people within the borough who are dying of drug usage aren't known to our services and aren't working with our services. Moving through, we then have a nice piece of data. I say nice, obviously it's not nice, but it's a good piece of data in terms of thinking about what's happening within the borough related to unmet need. As I think it's fairly clear, over the last 10 years, the level of unmet need for people who are using opiates and crack cocaine has doubled. Around about 63% of the individuals in Hackney who are using opiates or crack cocaine are not connected to our support services whatsoever. Twinning that with the piece of data about deaths arising from people who are not engaged in our support, I think there's a fairly clear understanding then that we need to be getting more people onto our substance misuse services books to try and avoid some of those drug deaths. Moving through, we then see that treatment exits are quite high in terms of people who are leaving with an unsuccessful outcome. For the core group of substance misuse, that's around about 33% of individuals leaving in an unsuccessful manner, but that actually increases to around about 42% of individuals who are using opiates and crack cocaine. Again, they're feeding into that level of unmet need. We have a picture then of people who potentially have already worked with services, who have become disenfranchised, who are no longer engaging in support, who go on to no longer think about what they may need to help ensure that they are healthy, well, and moving forwards in their recovery, who ultimately then are passing away. In order to try and deal with that, obviously we have things like the diversity sensitive models of support, which we're rolling out. We've brought forward some new training to try and ensure that substance misuse services are engaging with people in a better way to try and help keep them engaged. But we've also tasked our services with conducting more outreach. And this is actually something which is also being monitored by OHID and the Home Office. This is where the good news story comes in. Since June, we've seen a massive increase in the amount of outreach which our substance misuse services have completed. So rather than expecting a person to come to the Hackney Recovery Service or to come to an office to engage with support, we are going to meet people where they are, be that on the street, and we are doing that with our Ross Sleeping services, which were commissioned with a little bit of different funding earlier in the year, or be that at different satellite services or even people's houses. That should, in theory, begin to result in more people engaged with our services, both at the beginning of their journey into treatment, but also on a longer term basis. Indications are that this year we are seeing a reduction in drug-related deaths, though the data is a little bit porous. It's a bit tricky to try and get hold of some of that data, and we are working off some estimates based on some information that we've received from the coroners. That's it from me, really. Very happy to throw out to comments or questions from councillors or other members. Thanks.
Thank you, Simon. So any questions, comments? I don't know if Sean, you wanted to say anything from your perspective? Do you want to introduce yourself?
Yeah, thank you, everyone. Sean Lyons, Detective Chief Inspector for Project Adder. I'm the lead from the enforcement side, working very closely with Simon. Obviously, spoken to many of you already in various forums. Just to back up what's been said, really, Adder provides a real opportunity for the police and local services to work together. It really does galvanise the partnership. We've got a really strong partnership here in Hackney, anyway, across all the services, and obviously gives us the money and the resources to take it even further. From an enforcement perspective, my aim is to look at tackling the middle markets, so tackling drug dealing before it hits the streets of Hackney, and to ensure that we can clear those spaces, make the area safer, and which will allow the treatment teams to go in and do their work to divert people away from misuse and break that cycle. We're already hitting the ground running with that, and we've had a number of successful operations and seizures of multi-kilos of drugs before they're hitting the streets of Hackney, which is a great thing. Everything we're doing here, and Simon will obviously back this up, is under our banner of Operation Continuum, which is our drugs activity. It's a partnership approach, something we delivered to Tower Hamlets in 2017, we brought to Hackney last year, and it's everything we do is under that banner, so that's what we do going forward. We're already supporting drug-related death panels. This is new territory for us in police. Looking at the learning we've taken from other areas, Blackpool, for example, very high numbers of drug-related deaths up in the north, looking to bring that learning, and that is one of the beauties of ADA as well, that we can access that national learning and bring it back down to London. Diverting people away from drug misuse, looking at out-of-court disposals, how frontline officers can easily do that and refer directly into drugs treatment. So we're looking at the development of an app that officers can have on their device. This is very techie, it's way beyond me, but to divert them into drugs treatment services, and that's coming on. And what does it provide in terms of a legacy? Obviously, learning, making the community a safer place, and bringing the galvanising relationship between health, the council, and the police. So that's where we are with it so far. Thank you.
Sean, thank you very much. I've got one hand up from Francis Hayes.
This seems to be, given the number of people who your services have not been able to access, it seems to me a clear opportunity to pursue working with voluntary sector groups. At least some of who, I mean, I know your work with SWIM, but there will be other groups out there who either in terms of would be able to both access the sort of groups that you're sort of people that you're talking about, but also work with them, providing that they were able to get suitable funding. And I mean, for example, I was talking to a church group who'd received some money and had done a lot of work in terms of rehabilitating local members of their community. But their funding just stopped, and the people that they'd helped were then sort of left high and dry, because they were not people who wanted to go into statutory services. So I mean, I don't know how much you were pursuing working with the voluntary sector, but there will be groups out there who will be able to support you and help you, I think.
Absolutely, thank you for that, Francis. Yeah, we are planning on engaging with the voluntary sector within Hackney at large. One of the routes that we're taking to do that, we actually commissioned an organisation called the London Joint Working Group for the Reduction of Hepatitis C to undertake a piece of research into something called peer-led needle exchange across the borough. We are in discussions with them to look at including the voice of lived experience in much of our developments moving forward. And as part of that, we would then also be looking to bring online other voluntary sector organisations who can feed into our overarching aims, objectives and strategies. Alongside that, and a slight kind of pivot from that, just to kind of make sure that everybody is aware, we are also engaging with other statutory organisations and statutory services that do have a significant stake in working with substance misuse. So seeing Adi and Raina there today, Raina and I are doing some very close work to make sure that we've got the kind of safeguarding perspective of people engaging with substance misuse services down on lock, so to speak. We are also engaging with, again, like I said, our community safety teams, our housing teams, and have kind of a broad gamut of individuals and different organisations and services feeding into our delivery group, just to make sure that when we are thinking about substance misusers who are coming into our service, who do need support, who are very vulnerable, that they are receiving the correct response to meet all of their needs, not just their substance misuse needs. And I think Sean sort of touched very briefly on an aspect of that as well. We are working hand in hand with our partners in the Met to make sure that when somebody is vulnerable and they are found by an officer, that rather than there be an overtly punitive response to that person, a vulnerability referral is coming through into our adult social care teams, that we've got some adult social care oversight, and then that's coming down into our treatment services as well.
Thanks, Simon. So I'm going to give the last word to Rosemary. Rosemary Joara, hopefully your connection's
Yeah, I'm
seems to
good
be.
to go. I'm good to go for now. Thank you, Simon.
Last comment to you.
Yeah, thank you, Simon, for the presentation. I find it quite emotional at some stages. I was just sort of spinning from side to side in my chair, just hearing the facts, if you like, as to what this situation is doing, how it's tearing our communities apart. And just looking at some of the points that where there are weaknesses in current service, and I picked up on lack of professional qualifications for drug workers and the need for greater involvement of those with lived experiences. Now, this isn't a negative comment or an indictment against the good work that you're doing, but I know as a person who has actually, grasped the nettle and said enough is enough, we as communities need to come together and talk. And I got a bit of funding actually from Hackney Council, so thank you very much for that. And I ran a few community conversations, which was entitled Heart to Heart, because there were people's health, parents' health was being affected with, young children being out on the streets and so on and so forth. And it was having a knock-on effect. And we held a couple of conferences, which was halted by COVID-19, unfortunately, but we got off to a good start. And we engaged people who are ex-offenders, ex-criminals, ex-drug users who have turned their lives around. And so I hear you with regards to the people, the personnel, the organizations, the systems approach towards tackling, addressing the problems that we have in our homes and on the streets. But I am imploring you to look to the people, the residents, look to the people who are being impacted by these situations, people who have children living in their homes who are openly engaged in sort of, carrying drugs and all sorts of things around, and can't do anything about it because they're at risk of being beaten up or whatever by, cuckooing. Or it's all happening. I can't even begin to describe. So I'm just saying, yes, picking up on what Francis says, the VCS, we need to be in there, but drill down deeper. It's not just the VCS. It's not just those, the ones who have got all the infrastructures in place that can do a good job and so forth. I'm talking about the people who are intricately affected by these circumstances. You need to harness that sort of intelligence. People will talk in safe spaces, but you've got to find ways in which those who are trusted community leaders can say, let's get together. We've got a problem here. We need to talk about it. And we know some of the solutions. And if we work with you, we're not going to, it's a hard nut to crack. We're not going to deal with it overnight, certainly not by a long chalk, but we can make a few dents in what's going on. I hope that helps.
Thank you, Rosemary. Simon, just before you maybe comment on that in the last minute, Rosemary, thank you for that feedback and comments. Laura Sharp's also just asked a more practical question about the recurrency or otherwise of the funding. I understand it's for 2 years, but is that correct? And then I'll leave you to respond to Rosemary's comment.
Thanks, Chair. Yeah, so I'll respond to both. I'll start with Laura's. We've got 2 years worth of funding. Any underspend within that we might be able to use within the remit of those 2 years, or slightly go over into the first quarter of the year following. There have been no words on whether we've got funding beyond that in relation to our accelerator. I did try and dig into whether we had any kind of thumbs up or green lights with partners in OHID and Home Office this morning, but that they couldn't give me any words to say that it's definitely there. We do know that the Dame Carol Black review, which I did include as one of the kind of appendices to the paper, does suggest that there should be some more long-term funding coming from central government into local authorities. Alongside that is additional scrutiny and 31 other recommendations. And we do know that there is a cross-departmental thinking group, looking at what can happen from a central government perspective to make sure that drugs are still on the agenda and we are seeing improvements. So I think the long and the short is we're very hopeful that there will be additional funding. In the meantime, whilst we don't know, we are obviously, and again, I think my colleague Sean commented on this, we are thinking about what we can embed to make sure that there is a legacy if that funding is pulled. So a lot of the kind of systems approach and changes in developments in how organisations and teams and departments work together should, in theory, continue to be operative if we no longer have the funding and we no longer have the positions there. Of course, I think they would be marred without the additionality that is afforded through the funding, but they should still help, and they should still help to continue things. Moving on to your point, Rosemary, yeah, absolutely. I 100% agree with you. We in the Public Health Department 100% agree with you that the voice of those who are affected by things like substance misuse and then moving into the other areas of health and wellbeing generally needs to be heard in terms of us being able to help think about what needs to happen and how we can make developments. And then, of course, whether those developments meet the expectations, needs, wants and desires of the people that live in Hackney. From my perspective, with regards to the ADA rollout, we absolutely are looking at setting up a steering group to think on what we've been delivering so far, to think about how we can cut deeper, to think about how we can move things further forwards. As I mentioned earlier, LJWG, so that London Joint Working Group, alongside the Hepatitis Trust, are potentially going to be helping us do that. We already had the voice of lived experience, and this was people who are currently actively using heroin, some engaged in treatment, some not engaged in treatment, to think about what might help with regards to needle exchanges, so making sure that people can access clean needles, helping to reduce the risk of hepatitis C and those sorts of things. And that was a great success.
I'm just going to cut in for a second because we're nearly out of time and we just need to wrap up the meeting. But just the last 30 seconds. Sorry to interrupt, but just
no worries, Chair.
To give you a time check.
Fantastic. Yeah, so we're waiting for that report to come back, and the findings hopefully we'll be able to bring to this board, and we can again lift that up for scrutiny and discussion in due course. Thank you, Chair.
Great, thanks very much. And I know Sandra Husband's comment in the chat about trying to, if we don't get further funding, looking at ways at the same time as mainstreaming this work, because it's clearly so important. So Simon, thank you very much for your presentation, for colleagues' comments and Sean's input as well. I will just, in the last sort of moment or two of the meeting, I haven't been informed of any AOBs. I don't believe, I can't see any hands, so I will assume that's good. No, there aren't any other business. So in that case, I am going to draw the meeting to an end because we've just ticked up to 6 o'clock, which is our allotted time. So thank you everybody for your time, energies and engagement. Next meeting is on the 27th of January, which means I have to be the first to wish people season's greetings, do I? I don't know. So there we are. Let's leave it at that. Thanks everyone. Bye-bye.